Hello and welcome back. So today I'll be discussing an approach to eosinophilic lung disorders. This is our third video in the subsection on an approach to chronic dyspnea secondary to chronic focal or multifocal consolidation. This will be a very short video because the considerations are quite limited. Eosinophils, before we get into it, eosinophils themselves are a type of obviously innate immune effector cell in the immune system, and they tend to have different effects on tissues as compared to neutrophils and macrophages, because they are usually activated by Th2 polarized immune response, and they are primarily meant to target multicellular parasitic infections and therefore extracellular infections, like parasitic worm infections and infestations. So their functioning is quite different from that of neutrophils. They primarily kill parasites and other organisms that are outside of their cytoplasm. So they secrete granules that then secondarily contain enzymes that either digest the target pathogen's cell wall or directly damage the pathogen in some way. So when there is a pathological perturbation in this process, the same thing can target human tissues, and that as we go through the organ limited specialty topics, we'll see that eosinophilic involvement in the heart, the lungs, the GI tract, has a very specific presentation. So discuss regarding non-malignant and malignant cellular infiltrates resulting in focal and multifocal consolidations. Non-malignant infiltrate, like we had discussed previously, could be non-infectious or infectious, and malignant obviously just be malignant. And among the non-infectious agents, we had discussed about granulomatous inflammation or infiltration, eosinophilic infiltration, and lymphocytic infiltration. So today we are going to specifically be talking about the eosinophilic part of it, so the chronic eosinophilic pneumonia subsection. So see, eosinophilic lung diseases are a separate category of lung disorders that are characterized by, very importantly, an elevation in eosinophil counts in something, either in the blood or in a tissue compartment. Therefore, almost definitionally, they have an elevation in tissue and or blood eosinophil counts. They may also have a similar elevation in the peripheral smear eosinophil count, and may be secondary to Th2 polarized responses. So they may also be a concomitant elevation in IgE levels and RF positivity. So this is something that unifies all eosinophilic lung disorders. However, otherwise we divide them into two categories: primary eosinophilic lung disorders and secondary eosinophilic lung disorders. So I'll be discussing the secondary eosinophilic lung disorders very briefly, because essentially any disorder can produce a secondary eosinophilic infiltration. However, we'll be going into the details of the primary eosinophilic lung disorders, that is acute eosinophilic pneumonia, chronic eosinophilic pneumonia, and I'll be comparing it to a myeloproliferative / myelodysplastic syndrome variant, that is your hypereosinophilic syndrome. So that is what we're going to be talking about. So primary eosinophilic disorders therefore can be divided into acute eosinophilic pneumonia and chronic eosinophilic pneumonia. Hypereosinophilic syndrome is not a primary eosinophilic disorder. I've just used it as a comparator, because in clinical scenarios it becomes something that needs to be ruled out. The associations of acute eosinophilic pneumonia are indoor smoke exposure, a post hematopoietic stem cell transplant patient, and person who has been smoking. So these are very specific scenarios in which it develops. Chronic eosinophilic pneumonia has multiple associations, and these are likely just artifacts of the way we do epidemiological studies. Breast carcinoma and asthma, both of these are very common disorders, whereas histiocytic lymphomas and the systemic autoimmune rheumatic diseases that I mentioned, okay, essentially all of them, including, very importantly, a very rare vasculitis called polyarteritis nodosa, they are rare diseases. Okay, hypereosinophilic syndrome is as I just mentioned, a MPN MDS, that is myeloproliferative / myelodysplastic syndrome category, myeloid neoplasm, and we'll be discussing it under hematology later. So the main thing is that these three disorders show very significant differences in the epidemiology. So acute eosinophilic pneumonia and hypereosinophilic syndrome are male dominant, whereas chronic eosinophilic pneumonia is female dominant. And the age of presentation of chronic eosinophilic pneumonia is relatively younger than hypereosinophilic syndrome, and acute eosinophilic pneumonia occurs in the youngest subset of patients. Chronic eosinophilic pneumonia is the only entity that may have an associated history of allergy because there is Th2 polarization in its pathogenesis. Other disorders do not. Okay, coming to the clinical features. So all three disorders present with dyspnea, because we are discussing it under the heading of chronic dyspnea. Acute eosinophilic pneumonia naturally will produce acute dyspnea, which we'll discuss later. Okay, and chronic eosinophilic pneumonia and hypereosinophilic pneumonia present with chronic dyspnea, subacute to chronic dyspnea. Now, on top of that, chronic eosinophilic pneumonia, as the process is relatively chronic, there is associated collapse and there may be a pleural effusion. Okay, hypereosinophilic syndrome also may have this kind of presentation, but there is something that differentiates it from the others. That is, primary eosinophilic pneumonias, both types, do not have any other extra pulmonary symptomatology or involvement. So they may have constitutional features such as fever and malaise and night sweats, but otherwise they do not have any other involvement. Now, there are rare reports of chronic eosinophilic pneumonia having a skin, joint, gastrointestinal tract and peripheral nerve involvement, but probably that is due to a misdiagnosis. Hypereosinophilic syndrome, on the other hand, characteristically has other parenchymal organ involvement. So you may have cardiac involvement in the form of myocarditis, endomyocardial fibrosis, or restrictive cardiomyopathy. You may have hepatic involvement and renal involvement, and there may be joint involvement in the form of arthropathy or arthritis and skin nodulosis. The peripheral blood in all cases shows eosinophilia. However, there is a difference in the kinetics of the eosinophil count. So in acute eosinophilic pneumonia, within the first week of presentation, the eosinophil count doesn't rise. It rises in the second to fourth weeks. Whereas in chronic eosinophilic pneumonia, it is usually elevated, and usually it is more than 30% of the total count. However, it is hypereosinophilic syndrome because it is a malignant pathology where the eosinophil counts are extraordinarily high. They are usually 50,000 to 1 lakh in number. Now, other investigations, as I've discussed, all three are likely to show an elevation in IgE. All three are likely to show, therefore, also an elevation in IgG4, and are likely to be RF positive. So this is not something that indicates any specific pathology. Hypereosinophilic syndrome, in addition, could have a deranged LFT and KFT, could have elevations in mast cell markers, and an elevation in B12, vitamin B12 levels in serum, because it is a neoplastic process. So mast cell markers would be an increase in serum tryptase level. If you do a bone marrow, the bone marrow might show more myelofibrosis and spindle-shaped mast cells. Then elevation in IgE levels may also occur in the lymphocytic variant of hypereosinophilic syndrome. So this is specifically in the lymphocytic variant, as I have shown it here. Okay. Now, bowel fluid levels, obviously the eosinophil counts depend on the chronicity of the process. Pleural fluid and the exact differential count of eosinophils is usually more than 25% in patients with acute eosinophilic pneumonia, whereas it is more than 60% in chronic eosinophilic pneumonia and hypereosinophilic syndrome. Now, the last thing that we use to differentiate these disorders is their steroid response. Both acute and chronic eosinophilic pneumonia have excellent steroid response. Chronic tends to relapse, so there is a 50% relapse rate with chronic eosinophilic pneumonia. Hypereosinophilic syndrome is different in that hypereosinophilic syndrome, the eosinophils are dysplastic, so they are not as sensitive to steroid-induced apoptosis, so therefore it usually does not fall down. Secondary lung disorders is a wide range of systemic and pulmonary disorders which produce the eosinophilic lung infiltration. So they could be malignancies, essentially any, but specifically adenocarcinomas of the lung, other lung carcinomas, squamous cell carcinomas of the lung, and lymphomas and leukemias. Systemic autoimmune rheumatic diseases, specifically rheumatoid arthritis, Sjogren's syndrome, and sarcoidosis. Now, sarcoidosis and rheumatoid arthritis may seem a little counterintuitive because they have Th1 polarization, but they also can have reactionary Th2 polarization in some rare cases, so therefore they have eosinophilia. Also are pulmonary disorders, so the differential diagnosis is rather cheap. That is, C would stand for cryptogenic organizing pneumonia, H for hypersensitivity pneumonitis, E for eosinophilic bronchitis, A for asthma or allergic bronchopulmonary pneumonia, allergic bronchopulmonary aspergillosis, and P would stand for pulmonary Langerhans-Hill histiocytosis, PLCH. Okay. Now, just coming to, I'll cover these here because otherwise, there's a lack of continuity. So, allergic bronchopulmonary aspergillosis and severe asthma with fungal sensitization are not technically disorders that cause chronic focal or multifocal consolidation and chronic dyspnea. However, they are eosinophilic lung disorders. Okay, so allergic bronchopulmonary aspergillosis is actually a abnormal response to a specific fungus, that is your aspergillus, within the airways of a person who is genetically predisposed. They are committed to this because of the presence of these 4 mutations, that is C for CFTR, M for your MBL, mannose binding lectin, I for interleukin 10, and L for TLR variants. Because of this, they develop an excessive florid immune response dominated by eosinophilic infiltration against the fungus due to excessive Th2 polarization. And they have a specific HLA association. So the HLA association are HLA-DR2 and 5 and HLA-DRB1 star 1503. Okay, this is the specific haplotype that is associated, and therefore there is a type 1 that is Th2 polarized rather than type 2 hypersensitivity reaction. There is an important point here that the interleukin 4 receptor association is very, very specific. Okay, the other entity is your severe asthma with fungal sensitization. So here there is a immune response developing against fungal antigens, but not specifically against aspergillus. So it represents a severe asthma phenotype that has been worsened by a sensitization to a particular fungal antigen. Okay, moving on. So obviously, since the ABPA is specifically against aspergillus, there is it is only against aspergillus. Second thing is the immune response is usually more florid. So the IgE levels definitionally are actually more than 1000 international units per liter. And in severe asthma with fungal sensitization, the sensitization could be against any fungal species, even non-pathogenic species, and the serum IgE levels are usually less than 1000 international units per liter. So this is the definitional criteria for ABPA at present. There is a genetic association associated with severe clinical phenotype of ABPA, that is in the surfactant protein A2. So these are the two variants that are associated with worst clinical prognosis, and this is because surfactant protein A2 and surfactant protein D dampen Th2 polarization that is caused by increased IgE production. So that is a point that is given in Harrison. So I just wanted to bring it to your notice. So that brings us to the end of our discussion on eosinophilic lung disorders. I have specifically not covered eosinophilic granulomatous with polyangiitis because that is a vasculitis, and that will be covered as a part of the vasculitis spectrum, specifically the ANCA-associated vasculitis spectrum by me. So that requires detailed consideration, and what is covered in this topic is not sufficient consideration. Okay, so thank you, and I'll see you next time, and we'll be going into the imaging of focal and multifocal consolidation and how we can use that in narrowing down and specifically diagnosing disorders with focal or multifocal consolidation, and at many situations, obviating the requirement for a biopsy for